and the cervical spine in relationship to the atlas. So we measure those and do our best to make those as good as possible. Now, what does this neurologically rich upper cervical affect? And so what we've found over the time is that these are the main 6 things that it affects. We know that it tractions the brainstem and it tethers the dura all the way to the basement. It controls 2/5 of the blood supply of the brain through the inner transverse areae. That's the little holes right off to the side. Let me get a smaller one. This is a regular size. So the brainstem comes down through here, and the 2/5 of the blood supply of the brain comes up through here, and we'll talk more about that later. We know it controls CSF flow. I've got a great case that I'm going to share with you in a little bit, a few minutes, actually towards the end, that will show an amazing change in CSF flow. We know it does parasympathetic and sympathetic balancing in the autonomic nervous system as it affects the vagus nerve. We affect blood supply through this vertebral artery. It affects blood supply to 11 of the 12 cranial nerves. The jugular vein compression is with rotation of the atlas is relatively new information, and I'll share a little bit more with that. And then this is brand new, the pituitary gland. I'll share with you a little bit later before and after adjusting of an MRI. And we've got one of our colleagues in New York that actually owns an MRI, and he does an MRI before and after the correction. And he sees the pituitary gland is actually flatter on the pre-treatment MRI than it is the post-treatment MRI. So this hasn't even been written up in the journals yet. It's relatively new. So to get an idea symptomatically of what all this stuff does is what I call the blast. And this particular one is from Dr. Hauser. He's a medical doctor in Florida that does PRP in the upper cervical spine, mostly the alar ligament. He has found in neurological research that it affects all of this stuff. In fact, we're going to go over a case later in the broadcast here of postural orthostatic tachycardia syndrome in a 16-year-old girl that was struck in the head and it twisted her head sideways like that. So what I'd like to do is share with you tonight the who, what, why, and how of this particular problem and what we do about it as an option. So just a little bit of the history. D.D. Palmer discovered chiropractic in 1895. His son, B.J. Palmer, focused more in the upper cervical, and he had a technique or a system that he called a hole-in-one, where he considered the one atlas and has the hole for the brainstem to come down. And so he focused on the top bone. One of his students, Dr. Grostic, he went into three-dimensional evaluation where we have X, Y, and Z vectors. So we have X, Y, Z, and we'll talk more about that. And then my mentor, Dr. Roy Sweat, that developed the Atlas orthogonal instrument, took the 3D displacement and plugged that into an instrument. You know how the bar stories get started. The bar story was they wrote down on a bar napkin one night that you had to do 460 some things exactly right to get the perfect hand correction of an atlas with the hand correcting with Grostic's work. So what happened was Dr. Sweat, my mentor, had an engineering background, and he put that into an instrument, and this is what the instrument looks like. So let me reduce this down a little bit. So the patient would lay on the table here. The mastoid of the skull goes on what we call the mastoid block. And obviously, yes.
Oh, are you looking at slides for us? Because we only see you.
Oh, man. Okay.
Share the screen there at the bottom.
I thought I did. I'm sorry.
Yeah. I mean, you look very nice tonight, but
yeah. Okay. Let's try this again.
Hit the share screen, and then it'll come up. Okay, and there you go. Okay.
Okay. All right.
And
let's
then
try that again.
And if you can, open it.
Yeah.
The whole screen, that would be great.
Okay, why can't I get this to open?
Is it over here? Is this thing over here?
No, it's having to do with, it's got the new share. Okay, let's try that again. Okay, there it goes. It doesn't go away. You know, this, oh, here we go. All right. Now we should be able to share. There we go. Okay, so let's back up just a little bit. All right, thank you. Thank you for that, Bill. This was the first slide, and I burned through these. I thought you guys could see them. But we know that it affects brainstem traction of the tethering the dura. It affects 2/5 of the blood supply of the brain. We'll go over more of that a little bit later. This is the case we'll look at tonight, CSF flow, parasympathetic and sympathetics. We're going to share the type of vasovagal with you. The jugular vein compression and pituitary, those are more newer things that have come out. And this is the let me get rid of something over here. This is the slide that kind of shows the upper cervical instability. This is the one I was talking about that has to do with Dr. Hauser. He's a medical doctor that treats upper cervical instability. If they're very unstable, we struggle with them, but I'll show you a case later today that is incredibly unstable, that is responding extremely well to what we do. So this, once again, thank you again for letting me pull these pictures up. So this is what the instrument looks like. And we're able to change the X vector by raising this up and down. Again, we measure the atlas from the side, the top, and the front, which is XYZ vectors. And by plugging the formula into the instrument, we can change what we do to correct that. So this height changes the X vector. This protractor down here, this arm swings and changes the y-axis correction, and this changes the z-axis correction. So I can figure out how anybody's different from anybody in the world, plug it into our instrument and make a correction. So what's unique about Dr. Sweat's instrument, it's a percussion force, not an excursion force. So my first instrument in 1979 said Singer Sewing Machine Company right across the head right here. It was a pretty rudimentary instrument back in the 70s. And what they've done is they've taken the needle out and put in a stylus. This thing's called the stylus. And so it was an excursion force of whatever the throw of a needle would be. And I helped some folks for about 10 years. But this is a totally different animal where this is a percussion head that there's no excursion to it. So to use that example, or an example of that, I pulled up an old video of me when I was younger and maybe a little thinner to show you. If you'll bear with me a couple of minutes, it will show you the the percussion force and how the instrument works. As an atlas orthogonal chiropractor who uses a specific method to correct this atlas, I get asked often, how does the instrument work? Because the instrument, most patients don't even feel the instrument. So the easiest way to explain it is we measure this bone from the side, from the top, and from the front. So we can measure exactly how it's tilted this way. We can measure how it's tilted this way and this way. So we have a three-dimensional picture of how that is crooked. So if it is tilted, twisted, and bent, we can figure out the mathematical formula to move that bone back in the right position. And we use an instrument to do this. This changes the X dimension up and down this way. This y-axis rotation changes a certain number of degrees this way. And then the Z changes a certain number of degrees this way. So we can figure out anybody's kink, plug in the formula to correct it with the instrument. That instrument actually comes in contact with the skin above the atlas, right at the base of the skull, while the patient's head is on a pillow, and it's a very light force. So that's what that looks like. And this, again, this is a percussion instrument. This instrument, they started out with an 18-pound force and dropped down. The instruments that I use have a 6 to a 1.8-pound force. And there's multiple ways to adjust the atlas. There's technically, I think, around 8 upper cervical techniques. Now, a technique is a style, is a methodology, if you will, to analyze, evaluate the displacement and correct it. And all of us, all 8 of us, are obviously trying to restore physiological normal back with our procedure or our system. All of us function, or all of us focus on C0 or skull in relationship to the atlas in relationship to C2. So we also evaluate, I'll show you a little bit later, we evaluate spinous rotation of C2. So the atlas only weighs about 1.5 ounces, and the skull weighs between 9 and 17 pounds, as smart as, depends on how smart you are, I guess. And so I think of it like a bowling ball that sits on a golf tee. This is very light. And so again, we reevaluate the XYZ vectors. So there's about, as I mentioned, there's several upper cervical techniques. There's about 400 of us in the world that do what I do. There's about 300 of us board certified, I think. Grostic is the one that I talked about, that these two adjust the atlas by hand. This one and this one is kind of a political split. Your organization, I'm sure, has no political splits. Ours has many, and so is the last one down here. The top 2 or 3 are about the only ones that I refer to personally, because they're low force, no risk, and politically sound in that. So that's a little heads up of what we look at there. When I first started this years ago, I've been doing Atlas Orthogonal about 33 years. And this was pretty much my day. All day long was pretty much headache, neck, and arm pain. We know that it affects down the low back. About 90–95% of low back symptoms respond extremely well once we put the head on straight. If you've got a 15-pound bowling ball sitting crooked up on top here, then gravitational stress loads change all the way down. In fact, we'll talk a little bit later. It gives a physiological short leg. So this was my day for probably the first 10 or 15 years of my practice. And then as time progressed and over the last few years, this is more of my day. So this young lady is about 40 years old. And you'll notice that of our intake sheet, we evaluate for head, neck, and brain stem and all the different things like that. And I think there's 6 things that she did not check on there that relates to her gender. Now, obviously, there's probably more going on in this young lady, with this young lady, than just having her atlas out. So the way I look at it is from a neurology, biology affects function. In other words, neurology will change biology, and biology will affect function. So I'm going to do my best to restore her neurology and then see what we get out of this. So I typically treat for a time period of 30, the body repairs, we know the healing graph, the body repairs soft tissue is 30-day, 100-day, 1 year. And we find neurology, the nerves mostly take about 100 days to repair. So a case like this, I will treat for about 100 days, and we'll see that typically the headaches and the neck pain and the musculoskeletal stuff will typically respond quite well in a 30-day time frame. In a 100-day time frame, we should get more of the neurological stuff as far as the brain fog and different things like that. If in my world, if they don't respond in this 100 days, then that's a referral out to a functional doctor like yourselves, or I've sent many over to Dr. Clearfield. Just sent one yesterday, Bill, to that. We've got her we're 100 days into it, and we've got her about 70% improved, but she's overweight by 100 pounds. She has no energy, fatigue. I mean, she's classic thyroid or endocrine situation that typically responds really well with what functional doctors do. So I personally don't expect to see this gal being 80% in 100 days. My guess is she probably has some fibromyalgia, and she has been diagnosed with fibromyalgia. Typically, fibro cases, I only get about 20, maybe 30% better in 100 days. We do make them better, make them improved symptomatically, less frequent, less severe, but they need outside help. And so that's why we refer out. A different case, very similar to this one. She was a 40-year-old female, and I'll just read her list here. She was having headaches 3 days a week going into her eye with optical warping, migraines 3 times a month that would last 5 days at a time, left trigeminal neuralgia pain, left neck pain, left arm pain, tingling, numbness, left trap, left psoas spasm, left foot numb, vasovagal diagnosis, vasovagal syncope diagnosis, brain fog, memory loss, and sleep loss. So that particular package was very similar to this one, and she responded extremely well. So we are 100 days into her, just did our reeval, and the only thing she has left is a little bit of trapezius symptoms that will respond to maybe massage or acupuncture or something like that. So, and obviously we have these people reduce their sugar and their gluten and alcohol for inflammatory neuroexciters and things like that. So as I mentioned, when I get a case in like this, or the one that I just read that responded better than I expect this one to, we've been with this gal a couple of weeks and she is better. Like I said, her headaches are better. Her energy has not changed at all. And that's usually one of the first things they want back is the energy, and that takes the longest with what I do. But as we mentioned previously, the neurology, biology function, if I can restore normal neurology up in here, then my expectation is a graph of improvement over time. Everything gets less frequent, less severe with time. If you take the rock out of your shoe, it's got to get better. However, if we live by this chart, we die by this chart. And I say that jokingly. And my rule is if they're not responding in a 2 to 3 week period, this, as bad as this case is, maybe give her 3 weeks. If there's no response at that in 2 to 3 weeks in that case, I'm not going to keep treating, because if I've restored normal neurology for that length of time and there's no improvement, then that's not her problem. She needs to look somewhere else. So in evaluating a case like this, obviously we could go back and look at history, past history. Usually they have some past history. We're going to look at some a little bit later on that we can actually tell pre-puberty injuries from x-rays sometimes. So a lot of times it's old injuries. I would say 85% of my practice is old injuries that have come to haunt them. Could be birth trauma, motor vehicle accidents, football injuries. My own brother, when I took x-rays of him in college, he was in his early 20s and he had a spur on the lateral mass of the atlas. And in all my radiology classes, I had never seen a spur on the inferior border of the lateral mass of the atlas. And come to find out, he'd been dropped on his head when he was 2 years old out of a Safeway cart, head first onto the tile floor, which explains a lot about my older brother. So typically these symptoms progress. People start, I'd say start slow. They'll have an injury, they'll have headaches, neck, much like the first chart that I showed you, and then they progress into the second chart. And we also have to look at, I asked them, have you been diagnosed with Lyme? Have you, checked heavy metals? We see, we want to know if they've had breast implants, because we see a lot of this picture right here from breast implant cases. We found probably half a dozen of those in the last 2 years, that once the implants were removed, they exponentially got better. Again, I talked about fibro. If they have fibro, I am not going to make them 100%. I'm not going to make them 80% in my practice that I've observed clinically and observatory. So I don't keep treating them for that. I refer them out with functional, for a functional doctor. So what the two charts that I use most of the time in my office, as you can tell, I'm a visual learner, I'm a visual teacher. And so I use two charts in my office, and there's two main ways that we see that it affects the brainstem. It's going to affect, as the tethering comes down, it's going to affect the trigeminal cervical nucleus. It's in half of the trigeminal cervical nucleus is in the medulla as it gets sucked down in here. The other half is in the cord up at the top. And so we know, and we're going to go into the neurology here in just a few minutes, but the top 6 cervical nerve roots actually go up into the brain, affects spinal accessory nerve, which is the nerve to the trapezius. Spinal accessory is only nerve to two muscles, trapezius in the posterior and sternocleidomastoid in the anterior. So when this nerve, the way I explain it to patients is when these nerves get threatened, when they get insulted, they go up in the brain, they tell the spinal accessory nerve to contract the trapezius and guard and protect that. That's just like if I poked you in the eye, that's exactly what it's going to be like. So we know that the trapezius bifurcates, it splits into two pieces right up at the suboccipital. And the suboccipital, by the way, suboccipital neuralgia is the greater occipital nerve of C2. So when this nerve comes up through the trap, if there's spasming and contraction of the trapezius, it's going to make suboccipital neuralgia, and it's going to affect the greater occipital nerve of C2, which comes over here and affects the trigeminal cervical nucleus, which gives the myriad of symptoms that I see on a daily basis of I just had a gal in yesterday with high blood pressure. The research on that shows about I think it's 14 or 16 drop on systolic and about a 10 drop on diastolic with misalignment and correction of misalignment. That research was done in 2008 in Chicago. So we know that we can affect this stuff through the trigeminal cervical nucleus. The other chart that I do use all day long is up through the vestibular nucleus in the brain. And it gets its blood supply from C123 that comes down into here. And we're going to look at functional leg length a little bit later. We talked about that briefly on this chart right here, where it'll suck up the short leg, a short leg. But we see a ton of brain fog. This particular box right here is, I would say 80 to 90%, well, let's back that up. Maybe 70% of my patient population has part of this. Eye stuff, the second cervical nerve root goes to the ciliary muscle that affects eye movement for focus. So all of that are things that we see on a very regular basis. So when I get the patients in for evaluation, my thing is are they my patient? Because obviously medical doctors and osteopaths and everybody treats a lot of what this picture looks like. I mean, that could be a lot of your cases that come in every day. So my determination has to be, is this a case that is an Atlas orthogonal case? And is this a case that I think I can help, that I have confidence and competence that I can help? If I don't want to play. So we evaluate them in three ways. We back up just a little bit. What I want to do is I want to find out what's wrong with them. Can I help them? Am I the right guy? How long is it going to take? How are we going to do it that's different? There's only 400 of us in the world that do what I do. And how much is it going to cost? We go over that with patients too. So back to the neurology, biology. Neurology controls biology. Biology controls function. And so the first thing we do is evaluate the neurology, and we can do that with what we call scanning palpation of mainly C1 and C2. Sometimes there's a remnant of C3. On palpation, the C2 nerve root is always larger, and it's kind of stuck in between the joints of Luschka and the muscles in the back attaching to the spinous processes. So it's difficult to find. Back in the day when I taught this regularly, the basic classes, I think the scanning palpation was the hardest part because it's part of the art of touching. And for me, I describe it, it feels like a frozen pea that has a dent that sticks out when you're palpating it. And on objective palpation, I can feel that bump, and the patient can feel tenderness and pain when we touch it. It's an irritated nerve root. So we're touching the neurology of that, and that's the objective part of that. So the next part of it is we want to evaluate the biology part of it, and that is evaluating the trapezius muscle. Now I'm going to show you a little bit of neurology here in just a minute, but the nerve roots let's go there now. Let's just jump ahead and go there right now. So when I was in school 100 years ago, I graduated in 1979, and we were taught that the that the spinal accessory nerve was cranial nerve. It was a cranial nerve only. Well, what we know now is that the motor neurons of the spinal accessory, or I'm sorry, the motor neurons for the trapezius and the SCM actually come off of C1 through 6. So this was very big in my practice because my thing was I really wanted to get the atlas to hold a long time. My history was I'd had a lot of manipulation, I'd had a lot of injuries, and my atlas would not stay in place. And so I wanted to be able to get my atlas to stay in place because it is all about me. And I wanted to get my patients to hold a long time. So I felt like it was important to be able to palpate the biology related directly to the neurology to be able to figure out the integrity of what was happening. So we can palpate the tone and fibers of the trapezius muscle and evaluate what's going on in a neurological level that is going to come over and affect this. And by doing that, I can evaluate if there's a need to fine tune or further correct the atlas. In other words, if the trapezius muscle up here, mostly we find it up at C2, right up at the attachment, I'm sorry, right at the suboccipitals, right where it attaches in the suboccipitals is the most objectively important part of what I find, and we evaluate them supine with no weight on it, so the muscle shouldn't be working. And if there's taut and tender fibers, then I know that I have not neurologically cleared out C1. Because if I've cleared out C1, the trap should be relaxed. It should not have tension and tone in there. So we use that to evaluate the trapezius muscle, the muscle for the biology part. And as we look at, let's go back to fibro just a minute. And I wish I hadn't cut off this slide. My apologies there. But the attachment of the the attachments of the suboccipital are up here. There's an attachment here, first rib, attachment, the QL and the lats are split into attachments down in here. So I was checking the other day, and I found that these are all fibromyalgia points. So I mentioned a little bit earlier, was it true fibro? Is the case up in here that is diagnosed with fibro a true fibro case? Because 10 of the 18 points directly relate to attachments of that trapezius muscle that I can change the function of the neurology of that muscle. So as I mentioned previously, if it's not true fibro, then they will get better at the green rate here. If it's true fibro, then I'm only going to get them maybe 20, possibly 30% better. So that helps me affect, again, the biology part of it. And then the functional part of it, neurology controls biology, biology controls function, is we do a supine leg check. So we know, oops, cheating, going ahead there. We know that the leg length will change through the vestibular nucleus from effects of C1, 2, 3. In fact, early on, and a lot of the Atlas Orthogonal program is evaluating minute changes of our correction by evaluating changes in the leg length. We can discern changes. Do we have the Atlas completely cleared out? If the leg length is doing what it's supposed to do as far as drawing back down, even using the neurology of the trapezius, like I was talking about earlier, I found that most of the time we can bring the short leg long, which usually means a very good correction. So at this point, we've determined that they have neurological deficit. They have hot nerves, palpable hot nerves up here. We know that we can palpate this muscle and know, let's go to this one, we can palpate these points and especially up at the attachment of the suboccipital of this muscle, and we know we check the leg length, and that is an Atlas orthogonal case. I know objectively that I can help this person by correcting that with a 95% success rate of helping, in most cases, helping this patient. So at that point, we know there's a problem. but we don't know how to fix it. So at that point, we go into the x-ray. We mentioned earlier, we take a three-dimensional x-ray. So we take a sagittal view to measure the plane line of the atlas and the A to P, or in the sagittal view, the lateral view in through here. We take a to P projection, and we actually take two of these. I didn't show the other one, but this is an A to P projection. And what we're evaluating here is we evaluate the plane line of the atlas in relationship to gravity. And we're going to show x-rays here in a few minutes on these. We evaluate the relationship of this to the skull. So we have a system and a template system that we can divide the skull and measure within a half a degree of displacement in the upper cervical spine. We measure the cervical spine, and then we measure C2 rotation. We're going to look at all of those in actual patients coming up. Now, inter-doctor reliability back about 25 years ago. I'm sorry, I jumped ahead. This is the last view, which is the top view, the y-axis, and we use a template system to divide the cervical spine. Divide the skull, and then we measure the line of the atlas. Depending on when you start. I'm an old guy, and we used to use the intertransverse area, and now they're using the inferior border of the lateral masses. I personally use them both so that I can know, and sometimes there's some variances in the intertransverse area in here that they're not reliable. So I want to have a reliable anatomical product to be able to measure to correct a physiological problem. So in taking those x-rays, we're measuring our XYZ vectors. And I started going into this back about 25 years ago. They did an inter-doctor reliability study where they sent the analog x-rays to about 5 different chiropractors and said, what do you find? What's your angles? And they found that the inter-doctor reliability was somewhere around a half a degree of displacement, which is pretty good. Our new digital x-rays measure it within 1/100th of a degree. Now, they haven't redone the inter-doctor reliability. I personally believe we're probably accurate within about a half a degree. But we can measure the x-rays I'm going to show you a little bit later is measured into a half a degree, into 1/100th of a degree. So as we move down with the evaluation, we've taken these x-rays, but we also have to observe some other things going on in here. And all of the x-rays that I'm going to show you today, I've taken in my office in the last probably 3 weeks. So I didn't think it was really fair to go back 5 years and find some examples of exactly what I wanted to see. And these were pretty quick. So this is a degeneration with stair stepping. You can see C2, the back of C2. George's line should be a perfect arc coming down here, and the back of C2 does not line up with the back of C3. C3 stair steps on C4. C4 stair steps on C5. C5 is anterior of C6, and 2 of them are finally lined up together. And you'll notice there's minimal DJD at that point. So the degeneration occurs with long-term displacement over time. I use the example of, your tires are out of alignment on your car over time. The more miles you put on them, the faster they wear. Now, I'm going to bring up one more thing because this is kind of a fun little case right here. This particular case, this injury, I believe, was a pre-puberty injury. The reason it's pretty obvious it's an old injury because there's virtually no disc left between 3 and 4 and 4 and 5 in here, and there's huge spurs that take decades. You see this huge spur on the anterior. If you follow C2 down right here, all of that anterior of that's almost 1/4 of an inch of growth of new bone that has grown in there. There's big spurs down in here. So again, those take decades to grow. But this is a 60-ish year old patient, and she presented. Why do I think it's a pre-puberty injury? Because the growth plates of the body of the vertebra close at puberty or after, just a little bit after puberty. And the height and the breadth, you can see C7 down in here. Oops, jumping ahead there. The height and the breadth of the body of the vertebra should be pretty even. If there's been a pre-puberty injury that damages the growth plates on the superior and inferior, did I say anterior? And I meant superior and inferior end plates of the vertebral body, then it will be a pancake. So you can see that this height of C3 does not match the height of C7 down here. And so these are wider than they are long. And so that tells me a very high probability of a pre-puberty injury. So let's take a look at one more DJD case here. This was another one from about 10 days ago. And hers is pretty much only at one level. And you'll see it's also occurs right below the stair stepping. So what happens is these guys get in a car wreck when they're teenagers, and you can see the vertebral height of C3. Now, in the last one we looked at, C3 was the one munched down, and C7 was the regular size. In this one, we can see C3 is almost as tall as it is wide. Where we go down here to C7, it's munched way down and is wider. So I believe this was probably pre-puberty injury as well. Again, from the anterior border of the body of the vertebra, all of that is new bone growth, and that takes decades to grow. That's not a short-term thing. So we evaluate for DJD. We evaluate, this is kind of a fun one, instability. I touched with Dr. Hauser. We use Hauser, or we use the Centeno Schultz Clinic in Denver. That's geographically a little closer. And they do alar ligament PRP through the mouth. There are, I think, only one of maybe 2 or 3 that do through the mouth. If you go in posteriorly to do the alar ligament with PRP, there's a 2% fatality rate. And that's, as the last research article I read on that, the author said, it's a high risk operation. We don't recommend it. So I thought that was his final thing. But this is a probably 25-year-old gentleman. I got in a couple, 3 weeks ago. Here's the odontoid of C2. Here's the lateral mass of the atlas. Here's the lateral mass of the atlas. And this distance in here should be exactly the same. And this is one of the more aggressive ones that I've seen, one of the more worse ones that I've seen. And the lateral mass of the atlas should line up with that little dip right here. And the lateral mass of the atlas should come all the way out to the body of C2 right here. So that's way over there. Usually it's the alar ligament. The alar ligament holds the head on in extension with rotation. So rear enders, what is it? 27% of auto accidents in California are rear enders. So if somebody here's the screeching of the tires, turns their head, looks in the rearview mirror and gets tagged, they're going to tear an alar ligament for the most part. Now, the last I read, the alar ligament takes, I think, 288 newtons, which is a measurement of force, to tear this alar ligament in here. The ACL in the knee, don't quote me on this number, but I believe it's around 650 newtons. So this alar ligament is less than half as strong as, and that's what it looks like right up in here, where the alar ligament actually.
I'll be there tomorrow.
The alar ligament actually. Can you hear me, Doctor?
I got it.
Okay.
Sorry about that.
All right. Sorry. Okay. So the alar ligament actually attaches to the top of the dens. I don't know if you can see on my model here. I got a bigger one than a regular size. And the alar ligament comes up and attaches to the occiput. So it goes from the C2 dens and goes up into the occiput and locks this diarthrodial joint down. So if you think about it, if we go up here in this picture right here, the way that we're designed is we've got a wedge right here and we've got a wedge right here. And the way the skull sits on it, and it's a cup, I don't know if you can see it on Zoom here, but it's a cup. And so as it moves up, that's uphill, that it should not need me. Nobody should need me, because the way God designed us, that thing should settle back into place. But when this ligament is compromised, the ligament actually locks that whole joint. Here's the occiput, should be up above. It locks that thing in place. And so if that's been compromised, like this example we just looked at, this will probably not stay in place very well. So if we looked at this, when it looks like this, we take lateral bending to further evaluate the ligaments. So when we tilt this, and these are APOMs, anterior to posterior open mouth. That's what it's called. The mouth is open so we can get in there and see the atlas a little bit better in the dens. But when we open his mouth, the lateral mass of C1 actually slid off the other way. If you'll remember, in his neutral, he was slid to the right. So right is right. We're looking at it from the back, from posterior. And this one, he is slid to the left. And then if we go back the other way, he actually slides farther to the right, where the lateral mass of the atlas is off of the body of C2 in here. So this is going to be a very unstable one. And what does that mean to the patient and into treatment? That means that they will be probably more unstable. I set him, I guess it's been 2.5 weeks. I just saw him today, as a matter of fact, and his atlas is still in place for 2.5 weeks since the first time we set them. Using the system that we use, our first adjustment holds somewhere between 70 and 100 days now. 2018, we did an evaluation and they were holding about 70 days then. Now we're beating that a little bit with a little fine tuning, tweaking and some angles. But our goal is to get that to hold 27 years like mine is. So the last picture that I'm going to show on an x-ray to evaluate things that we look at is a ponticus right up in here. So this is a depends on when you went to school. I went to school, it's called a posterior ponticus. I think they just call it a ponticus now because they've got to shorten it for the millennials. But the ponticus is a ossification of the soft tissue that holds the vertebral artery in place right up in here. So from this point posterior backwards, again, here's the jaw, here's the back of the head. Sorry about that. This is posterior, this is anterior. So from about this point right here, all the way down to this white line should not have any osseous structures in it. So this happens in about 4 to 6% of the population. Our patient population is probably more in the 12 to maybe even above that has this. And the reason is because when that vertebral artery, as we mentioned, the vertebral artery, or I'm sorry, the atlas controls 2/5 of the blood supply of the brain here. So when the vertebral artery comes up and it does 4 90-degree bends, if we look at it from the sagittal point right here, it does a hoop-de-doo, right? And yes, that's a medical term. It does a little hoop-de-doo right here as it comes through there. And as we look at this one right here, there should be a soft tissue attachment that holds that in place. And if that's a bony osseous structure and you have displacement, you're going to end up with more, vascular compromise of that artery if there is a bony covering over it rather than just a soft tissue ligament. So I always want to evaluate for a ponticus to make sure they're good there. Real quick story about the pre-puberty injury. I got to go back to this because it's a fun story. So remember we talked about that they're going to have a flattening of this. And I had a 93-year-old patient come in. This has been several years ago. And I took x-rays of her and her neck kind of looked like this one right here at 93. And she had a really pancake C6 in here. I mean, C6 was only about half as tall as it should be. And she'd just been in an auto accident. And I said, wow, looks like you had a pre-puberty injury. This was pretty nasty. And she said, I've never had an injury. I've never had a car wreck. She was pretty adamant. So at 93, I didn't want to take her down and thump on her. So I just said, you're right. And the next day she came in and she said, I remembered last night that when I was about 13 years old, I was riding down a hill on my bike. I hit a bump. I went airborne, head first into a telephone pole, dropped to the ground, and I didn't wake up for 5 days. That qualifies as a pre-puberty injury. So that's one of my favorite stories of, yes, you can see a pre-puberty injury and tell them they had it from years ago. So we talked about the blood to the brain. We talked about the effects of that. And I promised you up above when we looked at, we didn't know, my slides weren't coming up. So I'm going to jump up to it again a little bit because we kind of went through this. We know the tethering. We know that we just went through the blood flow. We know it affects CSF flow. So there's a chiropractor in New York that is blessed with having an MRI machine of his own, and he does MRIs before and after treatment. And we're going to watch a short video, if we can have a couple, 3 minutes to watch. You may know this guy. This is off of ESPN, and this video was done for, it's called 30 for 30, and it was a video on the 85 Bears. They won the Super Bowl that year, and Jim McMahon, the Ditka years, the Bears, and Jim McMahon was their quarterback. And this is him a couple of years ago.
There we go. Well, this is what I do to try to keep my brain sharp during the day. I've got these puzzles, and it helps me to just try to remember things, you know, colors and where things go. I knew I was missing a couple pieces. You know, the doctor actually told me that this would actually be good for me to help keep my brain sharp and functioning, because it's, at times it tends to wander.
Jim McMahon is 56 years old. He now spends most of his time in his Scottsdale, Arizona home, where the dry desert air best suits his long list of post-football aches and pains.
This is my daily routine. What am I doing? What am I looking for?
But what the climate can't combat are the symptoms associated with brain trauma McMahon suffered as a player.
Bad headaches, pressure on my skull. I couldn't see very well. I couldn't talk very well. All I wanted to do was lay down, because my head was just constantly pounding. The pain had gotten so bad where if I had had a gun, I wouldn't have been here. And these two doctors from New York called me and said, "Hey, we think we can help you. We think we know what's going on." I said, "Let's do it."
Jim was diagnosed with early onset dementia. He had been complaining about a brain fog, as he described it, as well as he described it, a headache where he felt like ice picking on both sides of his brain.
While most concussion studies are focused on the brain, McMahon's team traces the effects of CTE directly to the upper spine, having found that neck misalignment can block the flow of spinal fluid and pool toxic proteins directly onto the brain.
Spinal fluid is white. That's the spinal cord. This is a spinal column. What you're seeing is a narrowing of the opening where the spinal fluid is supposed to come through.
Most times when you're having head problems, that's all they look at is the head. These guys are smart enough to at least look below the head at the neck and see if there was a problem somewhere, and they found my problem. They're not going to be able to reverse the damage. Like I said, that stuff was sitting in there for 20 years. How much it ate away at my brain, I don't know.
Using detailed images captured by the MRI scans,
You'll
McMahon
see he has the
targeted
same
targeted
instrument I do.
adjustments,
This is one of my
clearing the
colleagues in New
blockage,
York.
restoring the flow of spinal fluid.
This instrument is going to generate a gentle mechanical tapping that is just slightly going to put those bones right there to normal position. Okay. Going to sit back up.
First time they did this procedure, within 2 minutes, it was like the toilet flush. I could feel this stuff actually leaving my brain. My eyes cleared up, my speech cleared up.
The left is before, the right is after. So you see how much there is there? See how there's less in here? Instead of all this white stuff being in there, you're seeing more brain tissue than fluid. So it's already started to brain. Over the next several days, it'll improve more.
What damage it's done is done. I can't reverse that. But what these guys do for me, they keep me from having these bad pains, having these suicidal thoughts, having me function fairly normally while I can.
So as we take a look at Jim McMahon's brain, this is a cross section of that. And I told you when I started this thing how excited I am to do what I do, and to know that I can come to work every day and make that change in a person's body. I never plan on retiring. It's just phenomenal. So while we've got this MR up, just for real quick, I wanted to bring up one other thing. that we look for. If the patient has back in the evaluation, if the patient has a Chiari or not. What a Chiari is where the cerebellar tonsils, there's an imaginary line drawn from the clivus over to the posterior, the bottom of the occiput right here. And if the cerebellar tonsils are dropped over 5 millimeters below that, there's some controversy in there. A supine MRI is not as efficient to evaluate as upright, obviously the weight of the skull. In the last month, I've had a 4.8 millimeter drop of the tonsils that was considered normal, and a 10 millimeter drop that was diagnosed with Chiari, which, by the way, 10 millimeters is quite a little bit. So back to when we evaluate these x-rays, I wanted to show you a little bit about restoring the CSF there. And I jumped ahead in my notes, and I apologize about that. So what we do is we evaluated them with the x-rays. We calculated our XYZ vectors. We know that there's usually about 4 patterns or variants of those patterns. The more accidents they've been in, the worse the pattern is. So, for example, I recently had an automobile accident, MVA, motor vehicle accident. She was rear-ended, accelerated into a vehicle in front of her. Her car turned sideways, and another vehicle coming up beside her hit the rear end and spun her almost 360 degrees. So she had an acceleration, a deceleration, and a rotational injury all in one. And that is a more complicated pattern as a rule. So we figure out the pattern of kink, just like they did here with McMahon, and put the force in there. I jumped ahead a little bit. Also, I wanted to kind of explain a little bit about Dr. Rosa. He's in Rockport, I think it is, New York. And he has a MRI of his own, like I said, and he does a before and after MRI. He's the one that showed the pituitary and different things. So a lot of our research has come out of what he has seen in before and after. One other thing I wanted to point out about Jim McMahon is you'll notice that he wore sunglasses indoors when they were interviewing him. And I was thinking after, as I was prepping for this, I think I probably had a half a dozen people. I had one this afternoon that wears glasses indoors because of photosensitivity with their atlas out, because the C2 nerve root, again, affects the ciliary muscle. And if the C2 and C1 aren't functioning neurologically correct, ciliary muscle doesn't work. You don't get the contraction, you don't get the adaptation of light, et cetera, et cetera. So that's where I'm talking about. You get photosensitivity of neurology affects biology, biology function. So we put the stylus in there, we make the correction. You saw that with McMahon, and then we do an evaluation afterwards to evaluate changes. So we reevaluate all 4 things. First of all, we reevaluate the neurology. So when I touch those nerves up in here of C1, 2, and sometimes 3, it's if I'm pinching myself and I let go instantly, that should be better. And so that pain that the patients felt and the little frozen pea thing I was talking about instantly disappears. When I have it correct, the palpation of the tension and tone of the trapezius muscle at the attachment of the occiput in the supine position dissipates. If I don't have C1 right, the trapezius is not correct. And then the last thing we do is evaluate functional leg length. And if all of those things have done what we expect, what they're supposed to do with our system, then we take what we call post x-rays. And the post x-rays are post-treatment x-rays to evaluate what those changes are and restoration back to physiological normal. So we know from our exam, we're back to physiological normal. We want to look at anatomical improvements based on our x-ray. So we're going to look at the case of the postural orthostatic tachycardia that I talked about, a 16-year-old girl. And I want to draw it. This is the frontal. So we actually take this, left is left, right is right. And I want to draw your attention to the C2 or the C1 plane line. So the plane line is the plane line of the atlas. And this X right here should be parallel to gravity, which is this X over here. And you can see it's higher up there. And it measures out a 10.8 millimeter on an X-ray. The second thing I want you to observe is the C2 rotation. So we observe the C2 rotation in relationship to the atlas. And if you'll notice up here in our findings, the second one, the ACD is the kink up on top. That's how far the skull is kinked over. So that's 3.65 degrees. But look at the C2 spinous, almost 10 degrees. It's 9.59 degrees of C2 rotation. And when that happens, here's the brainstem that comes down here like this. So if I rotate C2, I'm going to affect brainstem torsion, a myriad of other things, and also the vertebral arteries. We come down there. That's what's being affected. Now, post-treatment X-rays, after we cleared out the objective findings of the scanning and the leg check and the muscle, we took our second picture, and now let's compare it to the first picture. The second picture, our plane line is 3.85, and originally that was a 10.8. So we've got what, 60% correction of the plane line. But look at the C2, and by the way, the top kink in the skull improved on this case, I think 4.65 down to, down to 2.33. So a third-ish, something like 30%, 33%, doing some fast math. But the big thing that changed in this was the C2 rotation. So the C2 rotation was rotated. I believe that hers is a rotational vector problem of a twisting, and I don't know if we can say politically correct Indian burn, but an Indian burn on her brainstem, okay? So the C2 rotation went from almost 10 degrees, we're gonna round that to 10 degrees, to 1 degree. We had over a 90% correction of the rotation of C2. Now let's look at the before and after rotation of C1. So this is our horizontal view. We drew our tangent line down through here. We have our rotational vector line in here, and we measured at 4.37 degrees. Now, the maximum that thing can rotate in nature in relationship to the skull is 3 degrees. So normal range of motion in rotation is 3 degrees in relationship to skull, maximum. Maximum rotation is 3 degrees. And this thing in a 16-year-old girl is stuck at 4.37 degrees. So again, I believe that between the rotation of C1 and the rotation of C2 is her major problem. And if we look at the rotation of C2 after, or C1 after we corrected her, it reduced down to a 0.36. So on this, we took it from a 4.37 to a 0.36, again, over a 90% correction in the rotation vectors of this person. So in my opinion, she had affecting blood flow to the brain that is going to come up here and affect this system here, some tethering of the cord, obviously probably some CSF fluid, as we saw with McMahon. And I believe that that is what's causing her postural orthostatic tachycardia. So she's a real fun case where we've only had her about 2-3 weeks, maybe a month now. And so that's a real fun one. So the difference that we see with these rotational improvements and displacement improvements can be real phenomenal. And usually if there's ligament injury, quite frankly, they correct easier because there's less resistance. Now, if you think about it, we use a percussion wave. Let's see if we can see here. The transverse process, here's the lateral, let me see if I can enlarge this a little bit here. The transverse, or the lateral mass of the atlas is right here, and the transverse process is right in there. And that transverse process on this girl is probably 3/4 of an inch deep in there. So on a petite 16-year-old, it's going to be about 3/4 of an inch deep. On a guy my size, it's going to be about 1 inch deep. So we use a percussion wave that you can't feel that's an inch away from the spinous process that moves that bone and makes this kind of a correction. And I think that's pretty cool. That's why I'm so passionate about what I do. Okay. So the reason that we're able to do that is this joint is a diarthrodial joint. So if we line it up with precision, and we can do that with our three-dimensional X-ray, three-dimensional instrument up here, if we can pull out all of the resistance, that diarthrodial joint, when everything is lined up, has a resistance factor of 0.005 degree or 5 resistance factor. I think that's the value of that. I'm not much of a physicist, but I know it's 0.005 resistance factor. So that's why we can have such a light force. There is no risk. There's no injury to the patient. I've had them wired together, screwed together. Amazing things, multiple fusions in the lower cervical spine. There's very few that we turn away. It was interesting that if you think about it, it's like a hinge pin, going back to our 0.005 resistance factor. If I take the door off the hinges and I put that door back on and there's a bind in it, I've got to grab a hammer and pound on that hinge pin to drive it back in place. But if I line that door up perfect, gravity will drop that same hinge pin in place. That's how our instrument works in relationship to different kind of adjusting. Okay. When I first saw this thing in action was in Seattle about 35 years ago. And I heard about it. I was adjusted by it. I believed in it, but I didn't understand it because it helped me, but I didn't understand it. And they had a video fluoroscopy, which is moving X-ray. And this was back in the VCR days. And you could see the stylus, the metal thing that came down in here about this angle. And I could see the atlas move when that stylus came down. And the atlas actually moved. Now, you can't feel the stylus. You can't feel anything happen. But I saw it move. So I watched it again. And I saw it move a second time. So then again, this was back in the VCR days. I rewound it and I focused just on C2. Oh, let me back up. When I saw C1 move, I saw a blur of movement below it, just too fast to see. So I rewound it and I focused just on C2, and C1 moved. I watched C2 move. And I, again, saw the blur of movement below. So I rewound it and watched 3 move, watched 4 move, rewound it and watched 5. I watched all 7 cervical move, and I paid him $20,000 for my first instrument that day, and I have 5 of them today. So that's the passion that I have with that thing. So it's amazing. So when we're looking at that, the next question is, I'm going to get into my notes here because I got off track just a little bit. My question that I get asked quite frequently is, chiropractors take this hit of once you have to go all the time. Well, I can tell you, this gentleman right here, I will probably manage him until one of us dies, and he's young, so I'll probably be the first one. So again, we try to get our people to hold as long as possible. And if they have an alar ligament compromise, it's really dramatic. We refer them to either Hauser or the Centeno Schultz Clinic in Denver or someplace like that. So we've been able to have some amazing cases, quality of life changes from severe. Real quick, I know we're about out of time here, but I had probably one of my most fun cases I still see. And he was 6 years old. He'd been evaluated by 3 university hospitals. He had the last one showed him in seizure. The EEG showed him in seizure, grand mal seizure for a straight 8 hours. And they took him off and they said, there's nothing we can do for him. He would lose consciousness. He would turn blue. The parents had to do mouth to mouth. There was no quality of life in the family. They couldn't go on trips. It was just a really sad deal. Anyway, she heard about me. We were able to make the correction. And within about 100 days, his seizures begin to improve, and he's alive at 21. I just saw him yesterday. Now he has autism, but he's a functional, reasonably functioning one. I had another case that had startle-induced seizures for 9 years. I mean, I could go on and on, some really cool cases. So that's about the end of my information. Does anybody have any questions? Thank you for your time and energy to watch, and I really feel privileged to be able to observe this and watch this.
That was great, Dennis. Thanks a lot.
You bet.
That was, a little something different than what we're mostly used to.
Well,
So-
and we refer to you guys all the time, because once we get the atlas in place and they still have issues, we've got to have somewhere to go with them. So in fact, Bill can tell you, I referred him a patient from 2 lectures ago from a gentleman that was talking about the fat coming into the cord in the lower lumbars. I had a patient like that, and he had losing use of his legs in his 50s. And I referred him over to Dr. Clearfield, see if we can get him some help. So it's pretty cool.
I'll let you know.
All right.
Haven't seen him yet.
Okay.
Dr. Burgess comments, of course, we can't let our DO pedigree go away. Did you know that Dr. D.D. Palmer studied with A.T. Still, our osteopathic founder, before 1895?
I did not know that.
Yes, and here we are meeting 127 years later. Yeah.
It only took us that long, huh?
Yeah. The rumor, or the story I heard, was that A.T. Still had his first osteopathy school class. It was a 1-year course, and D.D. Palmer was in that class, and then he went to Davenport, and he got rid of the MD part of it and just did the manipulation.
Part. Interesting.
That's what I've heard. So
well, honestly, I should know that in my history, and I may have learned it at one time for a test.
I don't know about a test, but okay. So anybody else have any other questions? Thanks, Dennis. That was really great. And like I said, like the guys like me, we don't really hear. This isn't the kind of information we spend a whole lot of time on. So where do you learn how to do this kind of thing?
Well, it is taught in 2 chiropractic colleges. One is it's taught in, I think maybe more than 2 now. It is an elective at Life West in Hayward. I've lectured down there many times. It's taught at Sherman College in one of the Carolinas, and it's taught at Atlanta, a college in Atlanta as well. But there's seminars. I mean, if a chiropractor's already been out there in practice and wants to do this, there's seminars that I've helped many guys that used to do different kinds of chiropractic that wanted to see different kinds of results, and yeah, it can be learned after you're already in practice.
Okay. So where do you get this machine?
From Dr. Sweat, from the Sweat Clinic. They kind of monitor that, because from a legal standpoint, to my knowledge, I mentioned safety. To my knowledge, there's only been 1 case on it. They took it into court. They had the judge feel it. They had the jury feel it, and they threw it out. But there's still, from a legal standpoint, you have to buy it from them once you've taken the classes, because it's obviously their copyright.
All right, so I can't go to like usedmedicalequipment.com and there'll be one sitting there, right?
There shouldn't be. I'm surprised that they haven't been picked up, because used ones are at a premium, very much a premium. Yeah.
Am I allowed to ask how much that thing costs, or is that
new? They're 26 now. I saw a used one on Facebook this week for 10.5, and somebody else said that's not going to last very long. They're more in the used category, 16,000, something like that. And I think new, they're 26.5. Actually, one of my patients builds them now, that they needed somebody to build them. And a guy that I treated from Chico, a couple hours away, the guy can build anything. And I said, hey, would you build them? And he's been building them ever since. So they're built right here in Chico, California.
Are there any disposable parts on that thing or no?
You know, the ones that I use are old. So I got into this 33 years ago, and I bought a brand called Spinalite, and I added up here some years ago. I use 4 of them in my office every day, and I have kind of a spare, if you will, out of fear, but an older one that needs to be refurbished. But of the ones I've used, I think I have 105 years of collective. So 33 with one, 25 with another, like that. And the only thing I've ever replaced on them is the foot pedal that sends the electrical impulse to make the correction. They are really bulletproof.
Okay.
The new ones are all motherboards, and we had some generations of the instrument that were less than that, 8 months out of a motherboard, but they of course moved away from those manufacturers.
Okay. Anybody else have any other questions? Lots of great classes and thank yous, and attaboys, and then from the audience here, and I think even Nakarado is at least giving you a nod.
Better.
That's as good as you're going to get from him.
Thumbs up, at least.
Right. So,
all right.
Okay. If anybody else have any questions, comments, and let us. So Dennis, we like to on our website, I'll put it in the chat. We like to post the video, that we have here on our website for everybody, if it's okay with you.
Sure. Sure.
And and it's where are we at here? Chat. Sure. And if you don't know what it is, it's aosrd.org/webinars. Okay. So aosrd.org/webinars. If you go to aosrd.org/previous conferences, which is right next to it, if you're interested in any of the previous conferences that we had, they are password protected. Get in touch with me, and we'll get you those links. And with that, thank you so much.
I appreciate it very much.
Very terrific. Please come back sometime. Please be here with us. Last week we got to watch you guys eat dinner, and that was quite delightful.
I'm such a neophyte. I didn't know how to stop my video. I had a crash course in
you're a neophyte. You saw I turned it on twice, and we couldn't talk, and I had the sound off, so nobody could hear it.
I'm old school, Bill.
Okay, so
thank you.
So thank you so much. So John, and you're more than welcome to hang around, Dennis. Unfortunately, I have a little bit of AOSRD business to talk about. We talked about it a little bit last week. So Thursday, I leave for the Lion's Den. I'm going to the AOA's House of Delegates meeting if you go to the AOA's House of Delegate meetings and go to resolutions number 502, there's a resolution that is up that to decertify our organization. Why? Because we've drifted away from our core values of rheumatology and autoimmunity. That's the alleged reason. Number 2, it was that we duplicate other subspecialties. And number 3, as a little bit of snark, they put in there that we only generated $19,000 for them last year. So if they throw us out, they're not going to. It's not going to be that much of a loss. So, a lot of you have sent me, letters, testimonials, and we're going to write a letter, and that will be placed into the record. And I'm going to attach your testimonials. All of you that have written them, most everybody that's still here, I have already done that, I see. The letter, the purpose of the letter is with the way travel is, if I'm not there and there's no opposition, this will just be passed without any thought. I've spent almost every waking hour since I learned about this. We didn't know about this until 3 weeks ago, June 24th, and it kind of didn't sink in until over the weekend that what they had really said to us. So, but I spent every waking hour formulating our response, and with the help of Dr. Cruz, who's part of our group, and a lot of my advice was that I need a lawyer there. So Dr. Cruz is a DO. She's lectured to us, as you know, many times before, ethics, and turns out that she's a lawyer also. So she's given me a terrific letter to, in lawyer terms with just facts. This is kind of it's a bit of an emotional thing for me, because this is like a hit from behind. It was, if you go to the House of Delegates resolution, it's 502-A/2022. It is on page 178 of 245 pages. Those of you who don't know, no one told us about it. We had no idea this was going on. This was done in the middle of the night. This was done in the middle of the night, and I thought it was at least gentlemanly of Dr. Clower, who's the CEO, and Dr. Jaimo, who's the president of the AOA, to at least give us a heads up about it. But turns out, again, it's good to have a legal mind. So Dr. Cruz did her due diligence and found in the bylaws we have to be notified between 5 and 40 days before the meeting if we're going to be decertified. And an email or a phone call counts as being notified. So I'm not so sure it was more to cover their sides, their end, than to be as a courtesy to us. And interestingly, a couple of things have happened this week. One of the things that they do, so on point 3, one of the things that they don't know, and I really don't like the projects that we're working on that are big projects or have a lot of implications, but have a lot of moving parts, and I don't like talking about them a lot, until they're that it's a done deal. So 2 years ago, the AOA and AMA CME graduate medical education CME granting bodies merged. And as you know, if you went to our conference in March, or if you looked our video course, then you know that you can get AMA credits and AOA credits. Well, this is a real boon to us. And as a CME provider, we've been negotiating with 2 very large outside medical groups. And one has 25,000 members and the other has about 5,000 members. And the 5,000 member group, we were just about ready to close the deal when this came down. Nobody in the AOA knows this, and this will be brought up. The value to the AOA for the bigger group would probably come in somewhere between $500,000 and $750,000 a year just in CME credits for their fees. They don't know this yet. They'll know about it on Friday when I make my presentation. So the purpose of the letter is in case, since there's such a bad travel disruption, that in case I don't make it, at least there will be something there. Your testimonials are most appreciated. They're going to be entered in the record also. Let me know if you want your name whited out, though. I had one person said, please don't use my name. They're afraid of retaliation. If that's the case, let me know. Or if you don't want me to enter it in the record, also let me know, and I won't. So I really appreciate everybody who's been supportive of us. What we did do, if you don't know, was about a year ago in May, we did apply and I naively, I thought it would be a simple name change from rheumatic diseases to integrative medicine. Well, they didn't like that at all, and they gave me all sorts of grief. I took the exact bylaws that we had written in 2019, and I just changed the name. And then all of a sudden, there was a problem with every other line in the bylaws. When before, it's the exact same ones, and there was not an issue with them at all. In fact, it's the official bylaws that the AOA accepted. They didn't like it, and they gave me all sorts of grief over it. And I said, you know what, forget about it. I have other things to do, and I forgot about it until, like you said, 3 weeks ago. So it's my belief that if we could change our name to integrative medicine, we would attract a much larger audience. I hear it over and over again that, you know, will you send us, you have such great content, and you have a great thing, but you know, I would have passed it over, or we've passed it over many times because we're not rheumatologists. So that's the thought process behind that. I hope I haven't shot ourselves in the foot. If I have, I deeply apologize to everybody. We will continue on no matter what. No matter what happens. So the process is they bring the resolution to the floor. It goes, then there's a discussion. The committee takes it under advisement on Friday night, and to make their final report on Saturday morning. I'm hoping that there will be a report, that there will be a groundswell of negativity so if the report is taken as is, the report says that we are decertified. So we need a no vote. That's what we need. So the other thing that happened was that on Saturday, now remember, a year and a half ago, we applied for this change, and they told us that they turned us down, and they said sounds like it's a whole new entity, and we needed to start over from scratch. So and that was the end of it. That's where I left it. On Saturday, this Saturday, just 3 days ago, I got an email from the AOA saying, we understand you want to start a new entity. Here are the instructions on how to do it. So I get the feeling they know that they're in the wrong here. So however it plays out, we'll be here next Tuesday. We're not going anywhere. We're not apologizing for anything. We are, we're going to go there. We're going to state our case. We're going to give them the facts. I think, the facts are on our side. I just found out today that there's a meeting of other executive directors the day before on Thursday between 3 o'clock and 5:30 in Chicago in the hotel where the meeting is. My plane lands at 2:15 in Chicago. I didn't know about this until 2 hours ago. So I'm going to try and make it. I talked to the director of the executive directors group, and which we are members of, and she said she would try and keep them around until as late as she could. So I'm going to bring our case to them first, so they'll hear about it on Thursday. If anybody else has any comments, questions, any other points that you think might be relevant in this case, please let us know. It's not a big deal. This group has been around for 50 years, and for them to turn around in the middle of the night and stab us in the back like this for no good reason is really, pretty unconscionable. If you go to the AOA's website and they talk about their values and their mission statement and how they have these lofty ideals and how they build the box, they don't sit inside of it, and how they're the holistic medical society. We're not the MDs. They're terribly two-faced on this. Dr. Spear's not on anymore. John, you may know. So apparently, way before me, there was a lot of bad blood between the people who ran our group and who ran some of the licensing boards. So you can't hear me? How did I fix it before? Audio settings. Oh, you You should have it. I got the volume all the way up. Okay, you can't hear me at all? I don't know what to tell you then. All right, anybody else? Is anybody there? I got everybody else muted here, so. I muted you. Oh, all right. I'll ask you, everybody, can I do it for everybody here? I don't know.
All right, we're unmuted.
All right, you're unmuted. The others.
They have to click their button that says unmute.
Okay, I'm sorry about that. So
Yeah.
I don't know what happened today. We're getting all sorts of craziness here. So
Hey, there's
everybody got muted again. I don't know what I'm doing here.
No, we're good.
Is okay. I don't know what happened here. I don't know why everybody's getting remuted here. Ask all to unmute. Okay.
All right.
Yeah,
Well, I want to give a big thanks to you, Bill, and to Dr. Cruz. I know you both have gone crazy in the amount of work you've done. So thank you.
Okay, well, that's okay. Well, I don't know. I don't know why we have to even deal with this as an issue. It's totally, not anything legitimate as far as I'm concerned. But for whatever reason, we're chosen. So we do not back down, right? We if they think we're going to go there and grovel in front of them, they're wrong. They're not. That's not what we're going to do. Now, Dr. Cruz gave me a very scholarly, lawyerly letter, much better than what I had written. I'd go there with a 2x4 and smash their heads in because that's what they deserve. So, to tell you the truth. But at the end of the day, whatever happens, we will carry on. We're not going anywhere, and it is my hope that because I had forgotten all about this. I mean, literally, I said this was not even a glimmer in my eye. It was they didn't want it. Okay, forget about it. If those of you know the history of A4M 20 years ago or 30 years ago now, Doctors Goldman and Klatz are DOs, and they came to the AOA, and the AOA threw them out, and they recently, not too long ago, became part of Tarsus Medical, which has a whole lot of big medical alternative medical groups. Live Derm is one, cardio metabolic health group is another one, and they have huge followings, and the sale price was, from my understanding, somewhere in the $60 million range. So these guys are putting their heads in the sand, we will carry on. We will do our mission. If we lose our CME granting credits, shame on them, and we will get them back in one way or another. Like I said, it was my goal a year ago to sort of morph into integrative medicine. I think we would have a tremendous following, and we would be the as it says in one of their sayings, in the AOA, they look to be the North Star for osteopathic physicians. They're the people to go to for guidance and leadership. Well, we're the North Star, and I think they're afraid of us. They will not cancel us. They will not put us down. We are not going anywhere. So with that, thank you all for staying with us. Thank Dennis is off, but Dr. Harding was really terrific. John, say something for a minute. I'll find out. I didn't look to see who's coming next week. So, and we will be here next week. Make no mistake about it. So,
I don't have much to say except that everybody's doing an exceptional job, exceptional job. Everybody has done an exceptional job. And this whole matter is a hit piece on basically integrative, alternative, complementary medicine. Those who are still pushing the drugs and surgery and ignoring the lives of the patient. That's what this is about. Not one person in our group has done anything unethical, awkward, or wrong. So I'm glad you're taking the stance you are.
Oh, and next week we have Dr. Pam Smith. Those of you who don't know who Dr. Pam Smith is, Dr. Pam Smith is the head lecturer for A4M. And I think she's going to be talking about, Hashimoto's or thyroiditis also, but I don't have the lecture down there. So we'll find out. So anyway, so if you go to an A4M lecture, you know, essentially their basic introductory, weekend, she's all over that. She's written about eight or 10 books that she lectures to thousands of students all over the world. So she'll be here next week, and we'll be here no matter what, same time, same station. Anybody else have any comments, questions, and any other advice, Dr. Nacarado? I see you're here. So we should get you to lecture for us, Jim, one of these days. So if you don't know, Dr. Nacarado he's a chiropractor and a psychologist, and he does chiropractic coaching, and he's been my coach for 8 or 9 years now. And when I have an issue, that's who I go to. And he's a great source of wisdom and strength, and sometimes he'll keep my head on when I go off. I don't know why we're getting the feedback here. So so with that, anybody else, questions, comments, anything in the chat? I don't think there's anything else. And then I'm going to say good night. I'm going to wish myself Godspeed, and we will prevail. I'm going to try and record it if I can, and we'll let you know what happens on Friday. Say a little prayer for us too, wouldn't hurt. So, okay. And John, I'll probably talk to Sylvia again later tonight, but thank her so much for, all of her help. I know she's in Hawaii, she's on vacation or something. I don't know. So she sent me this long letter, to use. And all I have to do is sort of fill in the blanks a little bit. So anybody else, thank you so much. Again, everybody here that I can see pretty much has sent us a testimonial, an group lesson. And I thank you again so much for being here. Dr. Pam Smith next week. Friday, we face the executioner and we will win. So have no fear. Okay. Thank you all. So good night. I'm done.